Thank you, Fergal. That was really awesome. We've seen the whole spectrum here from, people sitting in emergency rooms to this kind of collaboration at a very high level. I think there's something to be learned from each of those scenarios. All right, I'm going to give a very brief talk, and I think we'll still have time for some discussion. And then there's more discussion that's built in later in the day. Okay, let's see if I can share. And of course, I'm technically challenged. Here we go. You are screaming. Okay, good. I think you guys can see my slides. And yeah, so I'll just quickly go through, some other, it's really, I feel, a combination of, basic principles and some nuances in our practice. So just a handful of lessons learned. So what I've tried to do is just show a case and then, talk about one liner lesson learned. And these are my disclosures. So I think we all talk about the learning curve and we know it, but I just want to emphasize that, these two classic landmark articles from Dror Paley and Mark Dahl, I think is a must read for, the trainees or junior surgeons who are interested in, devoting a good part of their professional life to limb reconstruction. Advance. All right, there. So here's a case I saw many, many years ago, 2001. A young infant with, a 3 foot anteromedial bowing, very reconstructible fibular hemimelia. But it just turns out that she was one of, I think, 9 children and was a single mom with very limited resources. And, if you go back to what Dr. John Birch has published, a very algorithmic approach, and she would certainly fit in as reconstructible, needing 1 or 2 lengthenings with or without an epiphysiodesis, etc. However, given her social situation and just sort of the general feel, I opted, after discussion with the family, with the mother rather, to do an amputation reconstruction. So this child, around age 1 year, had a SIME amputation and a prosthetic fitting to coincide with her motor milestones. And there she is a few years later. And then a few more years later, I can't see the top of my screen, but I think here she is at age 15, just needed a couple of guided growths for the distal femur, which is unrelated to the tibial issues, and had a normal childhood. So I think the lesson learned here is don't make decisions based on imaging alone. And I think we've seen it time and time again this morning. Here's a case, recurrent. She's had, I think, multiple procedures for a very aggressive aneurysmal bone cyst of the distal femur. And with recurrence was sent from our oncology partners and has a deformity because the lesion's now probably, irritating and jeopardizing linear growth with asymmetric growth at the distal femur causing valgus. So all this patient had was, same day guided growth operation, half an hour's worth. And as you can see over time, not only did he realign and gain equal leg lengths, but some of his lesion improved. So, I think the lesson learned here is we just have to think biology and not just technology. And again, that's been resonated with all these cases this morning, to have a sort of principle-based mindset. And like Scott and others have said, improvise, but don't compromise. We've heard a little bit about Blount's, and here's a patient, 7-year-old with early onset Blount's, asymmetric, right worse than left. And this was a great learning case for me because, we did what I thought was an appropriate gradual correction on the right side and guided growth on the left. But as you can see, in a very short time, he had recurrence on the right side, and there'll be a bunch of slides to follow. And like this, the importance of needing follow-up after guided growth and realignment surgery has been, stressed by many of the previous speakers, and and that happens in all environments, including high-income countries. So this patient missed a few appointments, came back with a windswept deformity. The right side had recurred severely. The left had overcorrected with a broken screw. So I did my best to do a plateau elevation, got it better, but not great, and just took the hardware out on the left proximal tibia. And you can see what's happening to the mechanical axis. So on the left side, he went from extreme varus to valgus, and now he's drifting back to the midline. And on the right side, his mechanical axis is improving a bit, but not anatomic yet. So it's not over yet. So on the left, if you follow, he goes back to more varus. And on the right, I sort of defy one of the principles and go for realignment at the cost of slight malorientation of the knee joint with a guided growth of the right distal femur. And on the left, it looks like now he's got a physeal arrest of the left proximal tibia, which persists despite attempts at guided growth. So we end up with a plateau elevation on the left side, get a reasonable alignment. And then here he is at skeletal maturity with a reasonable outcome after a long journey. So I think the lesson learned here, again, we've heard this time and time again, that it's not over till the growth's over. So especially for guided growth, we need close follow-up till the patient's skeletally mature. Here's a patient from overseas with a distal femur fracture that was treated in a cast not too appropriately, came to us 2.5 weeks later. We tried, stretching him out, didn't work, did an open reduction and cross pinning with smooth K-wires. He ended up, not surprisingly, with a valgus deformity. And I think this is one of those things where sometimes, an MRI will fool you, because I couldn't see a physeal bar, and yet he kept deviating into valgus despite attempts at guided growth, and ended up in those days with a distal femoral osteotomy and lengthening and realignment. But what I failed to recognize was that his patella had subluxed and was still sitting lateral despite his realignment. So this is a bad situation where, young, healthy adolescent has bad patellofemoral arthritis with a dislocated or subluxed patella. And I think lately there's been some talk about this functional MRI of the growth plate called diffusion tensor imaging. And I think that's going to be quite an exciting thing for those who can use it. And it's really doesn't need too much technology. If you have an MR, I think there's software that can be modified to look at the biology of the growth plate and not just the structure. So I think the lesson learned here is address problems before they become irreversible. And then finally, my little journey through congenitally short femur. I'll show you maybe 3 or 4 quick cases, how at least my practice has evolved. So a few years ago, a 9-year-old with a congenitally short femur, pretty classic treatment with supraacetabular osteotomy to improve coverage, a contralateral epiphysiodesis, and then lengthening using external fixation with hinges across the knee to protect against knee instability with a deficient ACL. A more recent case where we do a guided growth for the distal femur with the help of my partner, Dr. Pandya. He does a physeal sparing ACL reconstruction. And then, we go in and do an intramedullary lengthening of about 5 centimeters and 5.5 centimeters. And then don't get too greedy. And here he is, early post-op, And then our plan is to do a second final lengthening, at skeletal maturity. And so for the younger patient, this is a 5-year-old with a congenitally short right femur, still do the guided growth. I feel she was too young for an ACL reconstruction or a classic intramedullary lengthening. So what's being popularized for the 7.5 centimeter leg length discrepancy, that's going to be about 11 centimeters at maturity, to do staged lengthening using an external application of an intramedullary lengthening nail, and get about 5 centimeters of lengthening, whatever the soft tissues will allow, keeping a close eye on the hip and the knee, doing some bracing to help prevent any hip and knee subluxation. And we weren't able to see these kind of results in the past. And I think this will be a good case discussion later today to talk about improvisations that can be done in settings of limited resources where you can get similar results with other devices and implants. And here's sort of the final case, 7-year-old. I think Scott Nelson knows this patient quite well. He did an excellent job with a super hip, and then the family moved to Northern California. And this kid had, I can't even see, but 11 centimeter leg length discrepancy, and predicted at 17 centimeters at maturity. And we used a much shorter nail. It was truly experimental in my hands, but luckily, he has consolidated. He still has a few more lengthenings to go, but as of now, he's got a good result. And I think the lesson learned here is, cautiously adopt new technology and make it relevant to your patients in your setting. So that's really just a quick summary of a few of the lessons learned. And I'm going to stop here.